Hello friends, welcome to a new chapter today. In this chapter, let us learn about modes of ventilation of anesthesia. So in this modes of ventilation of anesthesia, we have first positive end expiratory pressure. What is this positive end expiratory pressure? It will amount to partial pressure of oxygen. What is the normal partial pressure of oxygen? Normal partial pressure of oxygen is 90 to 100 millimeters of Hg. Okay, when do you call someone to have hypoxemia? We call someone to have hypoxemia if the partial pressure of oxygen, normal it is 90 to 100 millimeters of Hg. If partial pressure of oxygen is less than 30 millimeters of Hg, then we call it as hypoxemia. If the partial pressure of oxygen is between 50 to 60 millimeters of Hg, then we call it as mild hypoxemia. If the partial pressure of oxygen is 40 to 50 millimeters of Hg, then we call it as moderate hypoxemia. So we have a normal partial pressure, then hypoxemia, mild hypoxemia and moderate hypoxemia. Now, what are the methods of improving oxygenation? The methods of improving oxygenation includes: one, you will have to increase the fractional inspiratory oxygen pressure. Okay, how are you going to increase the method of oxygenation? The methods of oxygenation can be increased by increasing the fractional inspiratory oxygen concentration. Okay, and you will also have to apply the positive end expiratory pressure. You will have to apply the positive end expiratory pressure, and you will have to increase the fractional inspiratory oxygen concentration. That is the amount of or concentration of oxygen present in the inspired air. Normally we will have 21% of oxygen when we inhale it from the surroundings, but we can increase this 21% to 40% or 60% based on the requirement, and in some situations we may also require 100% oxygen. Okay, so this oxygen concentration can be increased. By that we will obviously increase the oxygenation of the patient, right? But always keep in mind that when you increase the inspiratory oxygen pressure, there is always an increased risk of patient to land up into oxygen toxicity. So this is something which you have to remember. Next, what are the complications of this using this positive end inspiratory pressure? The complications are: it will increase the intra-alveolar positive pressure. Because it increases the intra-alveolar positive pressure, it might cause barotrauma. Okay, it just doesn't include intra-alveolar positive pressure, it also increases the intrathoracic pressure also. Okay, because of that there will be increased venous pressure, there will be increased intracranial pressure. Okay, there will be decreased cardiac output, it also causes decreased cardiac output, and it causes decreased blood pressure. So these are the different complications which you see due to the positive end expiratory pressure, right? It also causes decreased perfusion and decreased urine output. Okay, how does all these occur? It's simple, it's quite simple. I'll just tell you by a diagram. Just think, if this is the heart and these are the lungs, right? Now what is happening is, we through the bronchi, see this is the bronchi. Okay, through the bronchi we are giving high pressure air. Okay, this high pressure air will increase the pressure in the alveoli, right? Alveolar pressure is increased, so it will also increase. Once the alveolar pressure is increased, it will compress the heart, right? It will also increase the intrathoracic pressure, right? It will also increase the intracranial pressure. Okay, once this will compress the heart, there is less, see, because of there is increased venous pressure, right? Because of increased venous pressure, the blood draining into heart is less, because there is intrathoracic pressure is increased. In the thorax the pressure is increased, so the blood cannot. So why is there increased venous pressure? See, the blood has to go from inferior vena cava to the heart, right? From the whole lower part of the body, the blood collects in inferior vena cava and it goes to the right atrium. But right now, because of increased thoracic pressure, the heart is in a compressed state, right? So because of that, this blood flow has been hampered or decreased, right? Because of that, there is increased pressure, increased blood which is left in the inferior vena cava and in the lower part of the body. This will increase the venous pressure. Okay, How is there increased intracranial pressure? Even this is in the similar way. See, from the brain, okay, through the superior vena cava, the blood goes into the right atrium. From the brain or upper part of the body, all the blood collects in the superior vena cava and it goes into the heart. But now what happens? Because of the increased intrathoracic pressure, this blood cannot reach the thorax because of high pressure. So blood is left in the cranium itself. So as a result, there will be increased intracranial pressure. Okay, got it, these two? Next, because there is less blood entering the heart, okay, then less blood leaves the heart. So that is, there is decreased cardiac output. So whenever there is decreased cardiac output, what happens? Cardiac output determines BP, right? So because of that, there is decreased BP. Okay, then in the lungs there is increased pressure. This will obviously cause increased barotrauma, right? Because of decreased BP, there is decreased perfusion to different organs. There is decreased perfusion to different organs. Yeah. So because there is decreased perfusion, when this decreased perfusion goes to the kidney, because of decreased perfusion in the kidney, again this causes decreased urine output. Okay, so this is how the complications chart is. I think you got something from this. Okay, next, as I have already said you, there are two modes of ventilation. We have controlled mode of ventilation and we have synchronized intermittent minute ventilation. We also have other modes of ventilation also, like assist control mode of ventilation, then pressure control mode of ventilation. We will deal with them in a minute. So first, if you see controlled mode of ventilation, here as the name says, controlled. So controlled is, you will give a fixed amount of tidal volume and a fixed amount of respiratory breaths per minute. Here the patient does not do anything. The patient does not do anything. There is no need for the patient to give any respiratory effort. Okay, only the pressure, only the machine itself gives the required amount of air for the patient. Okay, so what happens if this is followed? If this is followed for a long term, then one important disadvantage is, because the patient is given the required amount of oxygen by the machine, the patient has to be sedated, right? Or else the patient cannot tolerate the pressure and he cannot accept it. It is not easy. Okay, so as a result, he should be given heavy sedation and paralysis. That is one. Next, this might also cause V by P mismatch. Ventilation perfusion mismatch is high in this patient, and there is increased hemodynamic imbalance. Why? Because it might give large amount of oxygen which is not necessary, right? So as a result, there is increased hemodynamic imbalance, and also there is diffuse atrophy of the respiratory muscles are seen. Okay, in this process there is diffuse atrophy of respiratory muscles are seen. So these are the main disadvantage. It is not a weaning mode. You can't what is weaning mode? Weaning is a process by which you will ask the patient or encourage the patient to take breaths by himself, so that in a few days you are planning to remove the ventilator. When you are planning to remove the ventilator, you will wean the patient, so that you will encourage the patient to take good breaths, so that even if the ventilator has been removed, he will be able to take the breaths properly. Okay, then we have synchronized intermittent minute ventilation. In synchronized intermittent minute ventilation, here also the tidal volume is fixed, okay, and even the respiratory rate is fixed, but here minimum sedation is required because it is synchronized intermittent minute ventilation. That means if the patient can take the breath, it's fine. Okay, the patient can take the breath, then machine does not give any type of machine does not give the tidal volume. But if the patient cannot breathe, if the patient is not able to breathe due to any reason, during that time the machine will itself give the required breath. Okay, that is the thing. So even if he give minimum effort, the machine will start giving the breaths. Okay, so what are the advantages? Advantages are, it requires only minimal sedation. Then here V by P mismatch is minimal. Then there is minimal hemodynamic imbalance. So there is no respiratory atrophy. These advantages are correct. the disadvantages of controlled mode of ventilation have been reduced or improved in synchronized intermittent minute ventilation, right. Next, the next type of ventilation is we have assist control mode of ventilation. What is this assist control mode of ventilation? In this, all the breaths of the patient are actually, even if the patient does a small simple respiratory effort, they will deliver the adequate volume. Here in assist control mode, all the breaths are supported by the ventilator. Okay, that is the main difference between assist control mode. Here all breaths are supported or assisted by the ventilator. Okay, next, the next type we have pressure control ventilator. See, if we give 500 ml of tidal volume for everyone, see, some people may require less amount of volume, some people may require more amount of volume. So, right. So, if we give this particular amount of 500 milliliters and 12 breaths for each and every patient, this can result in barotrauma, because this can generate high pressures which the lung cannot take in, and as a result it can result in the injury to the lung. So, as a result, in pressure control mode of ventilation, the upper limit of the pressures are set. These we won't set the tidal volume in pressure control ventilation. What we actually set in the pressure control ventilation is we will set the intra-alveolar pressure is fixed here. Here we will fix the intra-alveolar pressure. Okay, because if there is more pressure, if this goes with more pressure, there is increased barotrauma, and this barotrauma can cause the alveolar injury. So, as a result, to prevent that, we will fix the intra-alveolar pressure here. If you see, this is the method of choice, especially in pediatrics, because pediatrics have small alveoli, right. They have small lungs. You can give high amount of volume to those lungs, because those lungs can't withstand high volumes and high pressures. Then it is also a method of choice for acute respiratory distress syndrome. By in acute respiratory distress syndrome, already there is hyaline membrane damage, already there is damage which is going on in the respiratory membrane, in the alveoli. So, it is not good for increasing pressure in that situation, that might cause alveolar rupture also. So, in order to prevent that, we will control the pressure, we will fix the intra-alveolar pressure. Okay, next. The next type is we have what is continuous positive airway pressure. In spontaneous route, the airway pressure that the ventilator gives is continuous positive airway pressure. Then this is pressure support ventilation, which we have said. There is something called as pressure support ventilation. Here there is spontaneous ventilation itself, but here it is associated with CPAP and PEEP together, called as pressure controlled ventilation. CPAP is continuous positive airway pressure. If combined with positive end expiratory pressure, then we have pressure controlled ventilation. I don't think all this is necessary. Till here these are really important. Then once you have learned that, now you will have to see how are you going to monitor the anesthesia. So, we will see monitoring of anesthesia in the next class. So, thank you guys for watching my lecture. Thank you.